Hello, everyone, and welcome to today's Third Thursday webinar from the Michael J. Fox Foundation. I'm Dave Iverson, a contributing editor at the Foundation, and I'll be your moderator for today's webinar on Parkinson's disease and blood pressure. On your screens right now, you'll also see a number of tips that we put up there for you to better access the slides. Sometimes I know there are technical problems with these, and these are just a few tips that we're putting on the screen for you to review as we get going. A couple of other introductory notes, and then we'll get started with today's topic. Just a reminder that you can log in every third Thursday of the month at 12 noon Eastern, 11 Central, 10 Mountain, and 9 Pacific to hear a conversation about a topic that's important to our Parkinson's community. So we hope you'll continue to mark your calendars and join us throughout the rest of this year. You can also always access these webinars on demand whenever you like if you're not able to join us live. As always, you'll be able to submit questions throughout the hour, which we will take as many as we can during the course of our discussion today. There's a little Q&A box near the middle of the screen, so just type your questions there and we'll do our best to get to your questions in the second half of today's webinar. And also, if you'd like to download the slides from today's webinar, you're able to do so. There's a box called Resource Lists on your screen, and then you can click on that, and then that document will open up in a new browser window, and you'll be able to save these slides if you want to share them with others, whether that's with your family or support group or others. You'll be able to take advantage of this resource on into the future. Okay, let's get started with what we're going to be covering in today's webinar. Our focus today, again, is on the interesting connection between Parkinson's disease and issues with blood pressure. So we're going to talk some about what low blood pressure in particular feels like, what causes that. Is that the disease, or is it the medications that we take for Parkinson's, or is it some combination? Then we'll talk about some of the ways in which you can contend with this problem, both the sort of non-pharmacological changes, things like diet or exercise or hydration, variety of things that you can do that don't necessarily involve drugs to deal with blood pressure issues. But then we'll also talk about the drug part of it. What about the medications? Are there medications you can take for low blood pressure? Or what can you do with perhaps your own Parkinson's medications that may assist in dealing with this particular symptom? And then as we wrap up, we'll talk a little bit about the problem of high blood pressure that can also occur in Parkinson's. And then what seems like kind of a strange counterintuitive thing, but whether or not there is a drug for high blood pressure that may also benefit people with Parkinson's disease. So we'll get to that towards the end of our conversation today. Let me introduce who's going to be with us on today's call. Joining us is Jody Wright. She joins us from Woodstock, Georgia. Jody was diagnosed 14 years ago, back in 2002, and she's someone who has had to contend with this problem of blood pressure in Parkinson's disease. Jody, welcome, and thanks for being part of our conversation today.
Thank you.
Joining us as well is Dr. Anna DePold-Poehler. Dr. Poehler is an assistant dean at Boston University, where she's also an associate professor of neurology within Boston University School of Medicine. Dr. Poehler, thanks for being part of our conversation as well.
Thank you for inviting me.
It's a pleasure to have you. And joining us as well is Dr. Veronica Santini, who's a clinical assistant professor of neurology and neurological sciences at Stanford University. Dr. Santini, a pleasure to have you be part of our conversation too.
I'm honored to be here. Thanks so much.
All right, let's get started with what we want to go through in our topic today. It's really an interesting topic, one that I think probably doesn't get enough attention, and one that a lot of people wind up experiencing with Parkinson's disease. So we're going to hear from Jody in just a moment who will tell us sort of what this feels like. But before we get to that, Dr. Poehler, if you would, give us a definition when we're talking about low blood pressure or fluctuating blood pressure in Parkinson's disease. What exactly are we talking about?
Well, that's a very good question, Dave. What we have found with Parkinson's disease over time is that in addition to the motor features, the tremor, the stiffness, the slowness, and the walking difficulties people may experience, people can also have difficulties with other issues or non-motor features. And one of these areas is autonomic problems. And the autonomic system helps regulate a lot of different things: blood pressure, heart rate, temperature. And in patients with Parkinson's disease, they can have difficulty with maintaining a stable blood pressure when they change positions. In a patient without problems with autonomic difficulties, when they move from laying to sitting to standing, their blood pressure will remain relatively stable. But in certain patients with Parkinson's disease who have autonomic problems, they can experience a drop in blood pressure when they go from sitting to standing, and we call that orthostatic hypotension or postural hypotension. And this drop can affect a lot of different things. It can impact their ability to walk, their ability to have good balance, and it can also affect their thinking.
And when you say that blood pressure drops, how much are we talking about? We all, whenever we get our blood pressure taken, we get those two numbers. There's a top number and a bottom number. I, for one, am never entirely sure what each of those numbers mean, but we know those numbers, 120 over 80, whatever it happens to be. When we have that drop that you're describing, when someone changes position, how much of a drop is it?
Very good question. So if there's a drop of 20 points or more in the top number, or the systolic blood pressure, or 10 points or more in the bottom number, or the diastolic pressure, then someone meets criteria for orthostatic hypotension. And this is usually done after 2 or 3 minutes of standing.
Okay, so now that we have kind of a definition in mind and know something about what this problem actually is, it's just as important to sort of get a sense of what that feels like, what the experience of it is for people who may have had this and not been entirely sure what to attribute it to. So Jody Wright, this is something that you experienced, and so describe for us what that was like, because this happened to you early on, right? Even before, as I understand it, before you were actually diagnosed with Parkinson's. What is it that you experienced?
Well, typically in the morning when I would get up, I would be very dizzy, and I would have my vision would be blurry. It would be difficult for me to see things clearly, and I definitely had fog brain where I couldn't think clearly or process. I'd also get a lot of pressure in my head and in my shoulders, and in my neck, head, and shoulders. I feel a great deal of pressure.
And all of those things, Jody, were going on before you were actually diagnosed with Parkinson's. Is that right?
Well, not to the degree. I mean, yes, to a much less degree. But after I was diagnosed with Parkinson's, of course, with time, it got much worse.
I see. And we just heard Dr. Holler describe that difference in number, that it's 20 points in the top number. So maybe someone has 120 in their top number, but when they stand, it goes down to 100 or into the 90s. Is that what you discovered too when your blood pressure was checked? Was there that kind of big drop in either the top or the bottom number?
Actually, yes, there was quite a large drop. I mean, sometimes I would drop as much as 50 points for my top number and 20 or more points for my bottom number. So it was pretty extreme. And sometimes my top number would go down to 85 and my bottom number would go down to 45 or 50.
So really big drops, and drops you experienced in both of those numbers. Dr. Santini at Stanford University, as you hear Jody describe those symptoms that she experienced, a couple of things I think maybe are worth pulling out from that. First, her description that she felt somewhat dizzy, lightheaded. She also said sort of foggy, like she couldn't really think clearly. So one of the things that I think is important about Jody's comment, and I'd like you to comment on, Dr. Santini, is that this is not something to take lightly. I mean, that these symptoms can be something that are serious and that affect everything from feeling dizzy to perhaps not being able to think very clearly.
That's exactly right, and thank you for bringing up this important issue, because I think the symptoms of low blood pressure are under-recognized. And so patients often experience lightheadedness when standing or even feel like they almost may pass out. The symptoms that patients experience really are unusual to them, because when there's autonomic dysfunction, those automatic functions in the body aren't working. And so our body is not used to experiencing these types of symptoms. People may have pressure or neck pain or a headache in the back of their head, they may actually lose their balance when going from sitting to standing. And it can often lead to falls, which can lead to very serious injury as well. Low blood pressure also can have an effect on the thinking. And just as Jody described, we often hear patients in the clinic describing this foggy thinking. And in fact, Dr. Holler and others have done research on this that has shown that patients with low blood pressure do have problems with memory. They have problems with executive system dysfunction, those high-level tasks and multi-step processing. And they also have difficulty with their motor planning. So, for instance, where to move their feet and their arms. And so in these scenarios, we know that when the blood pressure is treated and brought back to normal levels, these mental issues, these cognitive issues, can actually be reversed. So very important to recognize these symptoms early and treat them when they're there.
And we'll go into in just a moment some of the things that in more detail, both what's causing this problem and, of course, as importantly, or perhaps more importantly, what people can do about it. Just a follow-up question to you, Jody Wright, about what you experienced. Dr. Santini was just mentioning the problem of falls, which, of course, can be a serious issue in Parkinson's. And falls can take place both for balance reasons or muscle rigidity reasons, problems with gait, and so forth. But low blood pressure can contribute to that problem, it sounds like, as well. Is that something you have experienced? Have you had problems with falls since you began experiencing these low blood pressure symptoms?
Yes, I'm glad you raised the question because initially I went to my doctor to have, I asked him for physical therapy because I thought I was falling just from the disease progression. And after I realized that I had orthogenic, after I had the blood pressure issues, the falls stopped. I mean, they didn't stop, but they were significantly reduced. And actually, what had happened to me is I'd fallen down a flight of steps, so that was quite dangerous. And I'd fallen at the beach and actually broke my shoulder. So the falls are very serious, can be very serious with this disease.
Yeah, absolutely. And again, we're going to talk about what we can do because the good news in this discussion, as we'll get to in just a bit, is that there really are things we can do to help moderate these symptoms. Before we get into more of that and more about the detailed causes and solutions, Dr. Holler, one last point, and that's about the timing of this. I usually think of some of these autonomic problems, those problems with what used to happen automatically in our body, like blood pressure, as being things that more typically happen later on in Parkinson's disease. But Jody Wright is saying that she experiences this very early on. So, Dr. Holler, is this something that can happen at any point during that Parkinson's disease continuum?
Yes, Dave. In fact, it is something that can happen at any point. We definitely have patients that are more symptomatic from their autonomic problems in more moderate and advanced stages of disease, but there are patients who can have autonomic difficulties earlier in the stage of the disease. And as Jody mentioned, some people can have autonomic symptoms even before they get diagnosed with Parkinson's disease. So constipation is something we know very frequently can happen in people for years before they develop their motor symptoms. And in some patients, they can have some blood pressure fluctuations as well. Now, traditionally, the traditional Parkinson's patient, their autonomic symptoms may be relatively mild early in the disease and oftentimes undiagnosed. But as the disease and the symptoms get worse, often it's picked up. One of the things that we found in our research is that many patients who have autonomic dysfunction and also orthostatic hypotension, the actual drops in blood pressure, might not even have symptoms. So they might not have lightheadedness or dizziness. And as Jody said, some of the vision changes she was describing. So the only way we actually know that they have this orthostatic hypotension and are at risk for problems is to check the blood pressure in different positions. So that's why we do that as a standard practice to for all of our Parkinson's patients, not just ones who are symptomatic. Having the blood pressure checked early and at every visit is very important.
Good, I think a really useful point to make, that regardless of whether or not we feel some of what Jody was describing, having your blood pressure checked regularly as someone with Parkinson's disease is an important thing to do, not only perhaps when you see your neurologist or movement disorder specialist, but just when you're going to see perhaps your regular family practice doctor or another physician. Spend a little bit more time now talking about the causes before we get to the solutions. We've already talked about the autonomic issues and why that is involved in Parkinson's disease and affects blood pressure. But we also see this other point, Dr. Santini, about medications, that they can be part of the problem as well, because some of the medications we standardly take for Parkinson's disease, whether that's the dopamine replacement drugs, carbidopa-levodopa, or some of the so-called dopamine agonists, that they can cause problems too. So describe that part of it, if you would, Dr. Santini. What's going on with our Parkinson's meds that can make this low blood pressure problem perhaps even worse?
Absolutely. So we know that dopamine is the chemical that we're missing in Parkinson's disease. And so many of the treatments utilize dopamine in the brain in order to alleviate some of the symptoms of Parkinson's disease, particularly the motor symptoms, but also the non-motor symptoms. Now, what's the problem with dopamine? Well, unfortunately, it also has effects on the rest of the body. And so although we've created medications that we hope have minimal effects on the rest of the body and are primarily working in the brain, that's not a hard and fast rule. And so some of the dopamine effects do affect the rest of the body. And what we know about dopamine on the rest of the body is that it does lower blood pressure. So specifically, research done on carbidopa-levodopa, otherwise known as Sinemet, shows that this actually can increase the drop in blood pressure when we're changing positions. In addition, dopamine agonists, and some of those people know by the trade names Nupro, Mirapex or pramipexole, and also Requip or ropinirole. These medications also lower the baseline blood pressures. So we know that in addition to the disease having an effect on the blood pressure, the medications we're giving may increase that drop in blood pressure or even lower the baseline blood pressure. Now, some medications can have a variable effect on blood pressure, such as rasagiline or Azilect. That medication can sometimes raise blood pressure, and sometimes we can utilize that in certain patients. But for other patients, it can also potentiate the dopamine effects and therefore lower blood pressure as well.
And we also see on the...
Yeah, go ahead.
Sorry, I was just going to also note that as we see on the slide, there's also a reference that sometimes I think to other blood pressure drugs, and I think, sometimes we think that if we have Parkinson's disease, that's sort of all we have. But of course, you can have Parkinson's disease and have other health conditions that might, and some of those drugs, anti-hypertension drugs, so drugs that you would be taking for high blood pressure or diuretics, those can play a mix into this too. So Dr. Santini, just briefly, if you would, that one of the things that's important to do when you're dealing with these issues is to make sure, I would think, that your neurologist knows all of the drugs that you're taking, because they can mix together and have various impacts as well.
That's absolutely right, and thank you for bringing up this important point. In fact, we know that a good look at the medication list is very important. A very common scenario is that a Parkinson's patient earlier in life may have had high blood pressure, and throughout the course of disease with Parkinson's disease, their blood pressure begins to lower. This can often go unidentified if we're not measuring blood pressure in different sitting and lying positions. And so because of that, the high blood pressure medications may stay on to lower blood pressure, and that compounds the problem, as you suggested. In addition, a lot of the medications we may use for urinary problems may be causing problems as well. I recently had a patient who was put on a urinary medication by another physician and ended up going to the emergency room several times after passing out. And it was only after reviewing the new medication list that we were able to identify that that was the medicine that was likely lowering their blood pressure too much.
Really useful point. And it makes us again realize, Dr. Holler, that so many of these things are interconnected that we have to be aware of. You mentioned earlier the autonomic problems, and Dr. Santini did as well, which can include problems with bladder issues or constipation. And so all of these things are things that we have to be aware of. Dr. Holler, does that mean that if you start having one problem, an autonomic problem like low blood pressure, are you also at risk for having additional? Are they tied to these other autonomic problems, like problems with urological problems or constipation? Are these things linked in some way?
So patients who have problems with their blood pressure regulation because of autonomic issues are more likely to have other autonomic issues, as you mentioned. Yes. So potentially problems with urinary frequency, difficulties with constipation, sometimes difficulties with accommodation of vision, in fact. And those are some of the more frequently reported autonomic issues that can affect patients who also have orthostatic hypotension. So it can be a challenge if we're trying to treat urinary frequency, but also trying not to lower the blood pressure. And some of it is having an awareness of all of the medications that a patient is taking. And so we really advocate for a patient to have their medication list with them. And before a new medicine is added, that they ensure that their physician who wants to add a new medicine is aware of all the other medicines that they're on. And I spend a lot of time when I'm adjusting medicines for my Parkinson's patients communicating with primary care doctors, cardiologists, urologists to try and make sure we're all on the same sheet of music. And I think patients can be great advocates for their health in this way, too, to make sure they bring awareness to all of their physicians if they do suffer from autonomic problems, particularly this orthostatic hypotension.
Well, let's pursue then some of the important things that one can do if you're dealing with these sometimes connected problems, because it really does come back in some ways to the role of what the patient can do to make sure that that sort of communication exists. So let's talk about that. And one of those is being able to constantly evaluate your blood pressure. We've already heard Dr. Holler and Dr. Santini describe that measuring this is important as you change position from being in a seated or lying down position and then taking your blood pressure again when you stand up. But I want to bring Jody right back into our conversation at this point, because Jody, you've done some really interesting things to make sure that we have as good information as possible, as Dr. Holler was just describing, because you monitor some of this on your own, right, at home, and you kind of chart your progress. Tell us something about the way in which you make sure that that is constantly evaluated.
Well, actually, what I do is I just printed off a blood pressure chart from the computer, and I take my blood pressure 3 times a day. Not every day, but usually every morning, sitting and then in bed, sitting and then standing. And then if I'm having a lot of issues that day, then sometimes I take it up to 3 times a day. That's one thing I do. I also keep a chart to make sure I'm drinking enough water and taking in enough salt, because I know both those are important to support your blood pressure.
Really useful, I think, tips for all of us. And Dr. Holler, add into that if you would. I'm sure it must be, you mentioned being on the same sheet of music. I'm sure it's also music to your ears to some extent to hear someone like Jody describe the way in which she is monitoring this at home and keeping track of it, because you're then, or her physician, is the beneficiary of that sort of detailed information.
Yes, and I find that my Parkinson's patients are very good about reporting symptoms and reporting numbers, and so we work together on medical issues and blood pressure in particular. So Jody has a great system in place that we advocate for our patients as well, keeping a log at home. And you could either print out a log from the computer. We have people who develop an Excel sheet, some people who just write it in a notebook, whatever's easiest. And in terms of the blood pressure machines, most people are able to get an arm blood pressure cuff from their local pharmacy, CVS, Walgreens, etc., and they're able to monitor their blood pressure in the different positions, and then when I see them in follow-up, they bring their numbers with them. And we use that in the decision-making about what medications we need to adjust, what conservative therapies we can initiate or change. As Jody mentioned, there are quite a few things that we can do that are relatively easy, and even before we use medicines and in addition to medicines, that can make a difference in blood pressure. So staying well hydrated, using salt, and there are a variety of other conservative measures as well. But the monitoring of the blood pressure is very useful, particularly if you've ever been identified as having autonomic problems and then the orthostatic hypotension in particular.
I just put up on the screen some of those more kind of almost do-it-yourself sort of things that people can do to monitor and perhaps hopefully reduce blood pressure. Jody, say a bit more about what you do, and then we'll talk more with Drs. Holler and Santini about that. But you're saying hydration is key for you? That's something that you've discovered?
Yes, hydration is key. Also being very aware of what my blood pressure is. Whenever I'm out, I always I have several cuffs, and I even travel with a blood pressure cuff and take my blood pressure as needed. I also sometimes I wear support compression socks, and then I always share all my information with my MD, or with my neurologist, because it's just so important to keep them well informed.
Exactly. So, Dr. Santini, we've heard the point about hydration and maybe adding a little salt to your diet. Why is that important? Why does that work?
Yeah, so absolutely. I think one important point to mention is that these conservative measures really are very important. And it's wonderful if the patient has ability to really control their disease process a little bit. So doing all of these conservative measures, maybe in addition to medication, is very important for the patient to be doing. Now, as you mentioned, some of these things are as simple as taking in enough fluids. And so we know from data that only 500 cc's of fluid actually has the ability to raise that top number in your blood pressure up to 10 points or more. So even small amounts of fluid intake can really help. Now, to keep all of that nice water, we generally recommend water, but also we could recommend electrolyte fluids like Gatorade. To keep these fluids really inside the blood vessels, we need a little bit of salt as well. And so the combination of the salt and the fluid in the blood vessels really helps to raise the blood pressure overall. We also know that it's not just about doing the right things, but we also have to avoid certain things, certain behaviors. So prolonged standing, for instance, particularly if motionless, or very hot weather, or hot liquids, or alcohol. These are things that maybe we should be avoiding. Now, other things that we can do that are in the conservative route are compression stockings. Now, in the literature, the compression stockings don't have a lot of great evidence behind them. But for those of us who see people with blood pressure issues, we know that the compression or the support hose can often be very, very helpful. Another helpful measure is an abdominal binder. And the way that these tight devices work is they do not allow the blood to pool in the legs or to pool in the pelvis, where lots of blood can be stored. And so a combination of getting good hydration, good salt intake, avoiding certain behaviors that could be dangerous, and wearing compression stockings is a great start for patients with this problem.
And Dr. Holler, I know you're also a fan of compression stockings, and I think you made the point when you and I talked the other day that you see high-level athletes wearing them. So for those of us who might feel like, I don't want to do that looks sort of silly, or it looks like something a really old person would do, and that's not me, can perhaps get some solace from the fact that you see professional athletes using these as well.
Exactly. So healthy living is becoming very fashionable in many ways. So hydration, we see all the athletes hydrating well. They're all drinking their electrolyte solutions as well. Eating a healthy diet, that's also very important, making sure you get your nutrients in. And then the compression stockings that we find very useful in our patients, and the ones that they want to wear too, are often the ones that go from the ankle to right below the knee. And this can help, as Dr. Santini mentioned, in terms of preventing blood pooling in the legs. A lot of my patients feel like it improves their endurance. And in addition to those types of things, there are a variety of other types of wearable compression devices. So some people feel like when they wear their biking shorts, which are also compressing, those help them. A lot of my female patients and patients in general like to wear Spanx too. They feel like that helps to stabilize their blood pressure. So those type of tight clothing, tight devices, and then the specifically geared compression hose are all useful in terms of stabilizing, particularly when somebody is going from sitting to standing.
Good to know that you can make a Sorry, go ahead, Dr. Santini.
And I think, Dr. Huller, it's important to mention that oftentimes they're called compression sleeves. And so the ones that are a little less hassle to get on that athletes are wearing in those basketball games you're watching on TV, those are called compression sleeves. And so patients can go ahead and Google that and see if they can find some that are appropriate for them.
Useful. It's good to know that you can make an athletic fashion statement when you have Parkinson's disease. Always handy. All right, let's. I want to keep moving along as we have so much more useful information. Lots of good questions coming in too that we'll get to in just a few minutes. Before we enter into that part of our conversation, though, we talked a little bit earlier about medication and its role in all of this. So, Jody, when you first had your problems with low blood pressure, how did you contend with that? Did you adjust your Parkinson's medication? Did your physician add medication to lower blood pressure? How did that work for you?
Actually, my physician added medication for me, for blood pressure medication, because I couldn't cut down on the Parkinson's medication because my symptoms were too severe. So, so he added a blood pressure medication.
Okay, so that's a great point, I think. And Dr. Huller, again, this is another balancing act, right? Because as Jody was just mentioning, one way to, if you want to work on the low blood pressure problem, might be to reduce some of your Parkinson's medications that, as Dr. Santini was describing earlier, are medications that lower blood pressure. So if you take a little less of your Parkinson's meds, then maybe your blood pressure won't drop so much. But as Jody is saying in her case, she needs those. Lowering those Parkinson's meds isn't a good idea. So tell us something more, Dr. Huller, about how you as a movement disorder specialist make that assessment and that balance between what's needed for Parkinson's and what's needed to not have low blood pressure become too great a problem.
And this is a very, very important key feature, and I think this is where the movement disorder specialist can really be helpful, because with Parkinson's disease, it's not a one-size-fits-all type of issue. So every individual with Parkinson's disease has their own manifestation of both motor and non-motor symptoms. And then in addition to that, they have other medical problems. So for example, if a patient comes into me with Parkinson's disease, tremor, stiffness, that stooping, difficulty with their walking. They also have problems with their blood pressure dropping. They also have difficulty with urinary dysfunction. I need to look at all of those medications, evaluate the patient, and determine what the best course of action is. So if I can adjust their Parkinson's meds, I'll do that. But in many cases, like Jody mentioned, it's difficult to do. And then what I will do is talk about conservative therapies, potentially adjust and discuss with the urologist the timing of the urinary medication. So sometimes if we take the urinary medicines later in the day, we don't have as much problem, because patients with Parkinson's disease orthostatic hypotension often have their lowest blood pressures in the morning, but they might be able to tolerate their urinary medicines later in the day. And then I also look at medicines to add on to help treat the low blood pressure. And we see some of those, we see those featured here. So fludrocortisone, midodrine, and our newest medication for this, droxidopa. These medications can be very beneficial in terms of helping to stabilize the blood pressure so patients don't have as big of a drop of their blood pressure, or the blood pressure doesn't drop as low with the orthostasis. And these can be very useful. In addition, as Jody mentioned, these should be done in combination with hydration and salt, that type of thing. And in fact, taking pills, the Parkinson's meds and the medicines to increase blood pressure with a big glass of water is oftentimes the best way to ensure that you're well hydrated, that your medications dissolve and are absorbed well into the system, and then have the best impact. So one of the tips I give to my patients is that whenever you take your Parkinson's meds, take it with a big glass of 8 ounces of fluid, and that makes a big difference in terms of the overall impact, not just on your Parkinson's disease, the effect of the medicines, the blood pressure, but also can help with your constipation issues if those are problems for you as well. So keeping in mind all of those features, your movement disorder specialist can really be very helpful in terms of targeting an approach that works for you. And that approach may change over time as your Parkinson's disease changes, as your autonomic symptoms change. Oftentimes we need to adjust medication doses over time to ensure that you're optimized at every stage of your disease process.
I like particularly your point about taking your meds with a big glass of water, because it's one way that you can, if we should take in as much hydration as you're all suggesting, maybe that's one good way to make sure you do it, so that if you're taking your meds 3 or 4 times a day, that every time you do that, if you do it with a big glass of water, then that's one way of building adequate hydration into your daily schedule. I think that's a great tip. I want to go to some of our questions that are coming in, because there are lots of good ones. We have a couple of other points we'll come back to and talk a little bit more about the problem of high blood pressure in Parkinson's, and also about a new drug we're testing that we hope may slow the progression of Parkinson's disease that's tied to blood pressure as well. But let's hold and get to that in just a bit and take some of our questions that are on point with our current discussion. Allison writes in, Dr. Santini, what about the impact of exercise? Doesn't it lower blood pressure? So wouldn't that contribute perhaps to the problem? We had on our earlier slide that exercise is good. We always hear that in Parkinson's. Exercise is important. But Allison raises this problem. I thought exercise lowered blood pressure. So wouldn't that make the problem even worse? Dr. Santini?
Yeah, thank you for bringing up this very important point, because exercise is of utmost importance in Parkinson's disease. And now exercise has a funny effect on blood pressure. In some people, and depending on the exercise and the position that the patient may be in, the blood pressure can actually raise. And so it can get higher even transiently during exercise. But you're right that sometimes the blood pressure can also drop. And later on, if we've now been sweating excessively, that can make us a little more dehydrated, and then the blood pressure can also drop later on. So what I would recommend is actually, before starting an exercise regimen, that patients have an understanding of what happens to their blood pressure during exercise. And so taking blood pressures before and perhaps in the middle and after exercise might be of utmost importance. A great way to start an exercise program in Parkinson's disease is to work with a physical therapist. And we would advise sessions with physical therapists at least once a year, or as much as your insurance company will pay for, frankly. And so the physical therapists are really experts in this realm. And they're checking blood pressures and making sure it's monitored. And it is not infrequent that I am being contacted by physical therapists and saying, hey, the blood pressure is really dropping during these times, and we think that maybe some adjustments can be made to medications. So thanks for bringing up that important point. All of these things, though, should not prevent you from exercising, because we know that lower extremity exercises and really strengthening those leg muscles might actually help the problem long-term of blood pressure issues.
Jody, is that something you do before you walk or whatever other exercise you're engaged in? Do you monitor the way Dr. Santini was describing, taking your blood pressure maybe before and after? Is that one of the things you do as well?
Yes, it is. And also, I try to exercise either early in the morning or evening when it's not so hot during the day. I find that to be better. And I also swim a lot in the swimming pool, which is I think you don't have to worry about sweating so much and losing fluids. And I ride my bicycle quite a bit. So all those are very helpful.
Really great points. Dr. Holder, a question from John. What about the use of caffeine? We were talking about the importance of hydration. Is coffee one of those things you have to be wary of to use as one of your hydrating activities, or is caffeine problematic when it comes to blood pressure?
Yeah, caffeine is a double-edged sword. So caffeine can increase blood pressure, but it can also dehydrate people and give them later on problems with drops in the blood pressure. So usually we have people, if they're going to consume caffeine, do it in a very limited amount, and we usually talk to them in particular about what time of day might be best for them to have a little cup of coffee, depending on their blood pressure and the trends. But large amounts of caffeine, just like alcohol, can be very dehydrating, and those don't count into the total amount of good hydrating fluid ounces that we advocate for every day. So I say for every cup of coffee you take, you got to subtract all those ounces from your total hydration. And people quickly find that they're able to, if they do consume caffeine and alcohol, do it in very moderate doses, and then again, usually after a discussion with their movement disorder specialist.
So it sounds like you're saying if you have either a drink or a cup of coffee, then you owe your body 2 more cups of liquid or Gatorade. Is that about right?
That's typically what I say, yes. And so people who kind of have been in the habit of drinking a pot of coffee a day or big containers of coffee oftentimes change their ways a little bit to very good effect.
Question from Mary, Dr. Santini, who asks, if you increase your blood pressure, will that increase your stroke risk?
Oh, this is such a great question, Mary. Thank you for bringing that up. And I think this goes to your point earlier, Dave, that high blood pressure is not good for us as well. So we do have to monitor that. And often what we find in Parkinson's disease is that patients may have high blood pressure when they're lying down, lying flat, but low blood pressure when they're standing up. And so this creates a little bit of a problem for us. So sometimes what we might find is that your movement disorder specialist or your cardiologist may need to put very short-acting high blood pressure medicines on at nighttime when you're lying down flat, and blood pressure boosting medications during the day when you're up and moving around. This also brings up another point about the timing of blood pressure boosting medications. So we know that oftentimes the worst time for low blood pressure is in the early mornings, very similar to what Jody had mentioned earlier in her description of her symptoms. And so early morning symptoms or even throughout the day, but we try not to dose any blood pressure boosting medications after about 4 p.m. or so. Some of them we really dose in the mornings because we don't want those blood pressure boosting medications to take effect when they're lying flat. Now, what kind of effect can this have on patients if they're having high blood pressure when they're lying flat? Well, for instance, patients can experience problems with thinking long term or increase their risk of stroke. And so we do worry about those higher blood pressures. Now, high blood pressures in these settings, we would recommend that you're talking to your doctor if your blood pressures are above the top number above 160 or so. And it may not require any intervention, but however, we really want you to talk with your doctors at that level. When the blood pressures are the top numbers reaching 180 or so, that becomes a little bit more dangerous for the stroke risk factors.
As you were describing this, Dr. Santini, I put back on the screen this other additional point that we did want to get to today, which is that you can sometimes have high blood pressure in Parkinson's disease. And Dr. Holder, at this point, people may be feeling, I know I at least feel to some extent, that this is getting to be unfair. Not only do you have Parkinson's to contend with, you have low blood pressure, but then maybe you have high blood pressure, and you have all of this sort of complicated stuff to contend with. And Sandra asked this question, which is, can you take orthostatic hypotension drugs and then also take high blood pressure drugs at the same time? So help us sort this out.
Yes, and I agree. It has become a bit complicated. However, what I would say is that because we've been paying attention to this more over the past 5-10 years, we've actually made a huge impact in people's quality of life. So patients with Parkinson's disease, before people were recognizing orthostatic hypotension, had much more common falls and symptomatically felt poorly and had reduction in their quality of life because they didn't necessarily want to get out and about as much. So now that we've been able to recognize this as an issue, the orthostatic hypotension and also the supine hypertension, we're able to intervene with these conservative therapies, so hydration, compression stockings, etc., and then also with medications. And although it is more complicated, it makes a big difference in quality of life, as I'm sure Jody will be able to tell us about. One more thing I would say in terms of the high blood pressure is that though it happens more commonly in the evening, there are ways to easily adjust it as well. So, for example, adding an extra pillow to prop the head up can often help the blood pressure so that you're not necessarily laying flat. And then if your blood pressure is getting high, sitting up for a little bit of time or even standing can help with bringing the blood pressure down. So although there are trends towards drops in blood pressure with standing and high blood pressure when laying, not everybody has all of these problems, and in many cases, simple fixes can make a big difference in people's lives.
All really useful and important points, and brings up again, I think, in this complex situation, that doing what Jody does, keeping track of all of this and providing that information to our various physicians, including, of course, the movement disorder specialists, is really important. I want to get on to a few more of our questions, and we'll come back a little bit later to some new research in this area. But Jean writes in, what is the low blood pressure number that you should look for? Another individual wrote in, what are the Goldilocks blood pressure numbers to try to maintain? Is there an ideal, Dr. Santini, in all of this? Or is there a target number that people with Parkinson's should shoot for, either that high number or the low number, either the systolic or systolic blood pressure numbers?
Yeah, absolutely. I think that this can be a little bit of a moving target depending on the patient. We don't get too obsessive about low numbers that maybe aren't causing symptoms, but we know that when the top number really goes below 100, that's when patients are experiencing the most symptoms. But this can be variable. Some people actually have blood pressure sitting or lying down that start off quite low. So for what may cause symptoms in one person may not cause symptoms in others. However, I would say that if the top number is going below 100, generally we would like to either maintain the blood pressure around that level or a little bit higher. I would say that in addition, the patients who might be experiencing symptoms at higher numbers, those patients we might want to take a little bit closer look at their blood pressure values and maybe the log that they've kept to see if we can't optimize them a little bit. And oftentimes those patients, a little bit extra fluid hydration, salt, or some compression stockings might be just what they need.
Question coming in on the salt question is how much salt? Is there an idea? Is there a way that we should target the amount of salt, and if so, how much is that someone with Parkinson's should take in, Dr. Santini?
Yeah, this is also difficult to know, right? And so we know that for people what I usually recommend is for people who like to eat salt, who don't mind salty items, let's just add salt to each and every meal. So not just table salt added on top of your meal, but actually eating a salty item with each meal, whether that's salted pretzels or deli meats or soups or preserved foods that have a lot of sodium within them already. Now, if you're a person who just doesn't like the savory foods and really doesn't like salty items, then we would recommend likely taking around a gram of salt 3 times a day with each meal. And sometimes those can be prescribed in salt tablets. But then, again, this is all based on the individual person's blood pressure profile. And so we do need to know what their blood pressures are so that we can advise whether they should be taking salt or not. I wanted to make one other safety mention. For those people who have cardiac issues, independent of their Parkinson's disease. So for instance, they may have a little heart failure. It's very important that the neurologist is also talking with the cardiologist and making sure things like salt or increased water consumption or even some of the medications we use are safe for that individual person.
Thank you, Dr. Santini. There's a question that I wanted to get to that came in early that I want to make sure that we talk about as well, which is a question about having symptoms, low blood pressure symptoms, even when your physicians don't change. So this individual, Bobby, writes in that her mom passes out even when she's sitting. So she's not changing positions. She's not getting up and down, but is experiencing, sounds like very acute problems just while still in a seated position. Dr. Holler, any thoughts on that?
Yeah, so that's usually indicative of a more severe autonomic problem. And in those individuals, then medications are often required to stabilize the blood pressure so that the person can feel comfortable in a seated position. That's more a more serious issue in terms of more moderate to severe disease, but still able to be managed with medications and conservative therapy. So there's still improvement that can be made even if somebody is passing out in a seated position. And I also wanted to add, too, that when we have patients who have blood pressure fluctuations with Parkinson's disease, what we like to have them do, as I mentioned before, is keeping a log of their blood pressure, and then we monitor that when they come in to see us. And as I said, we mention and we adjust the medications over time. So somebody may have minimal issues early on, but they may need more aggressive intervention as we proceed. And along with that, people may develop other medical complications independent of their Parkinson's disease. So as Dr. Santini mentioned, they may develop some cardiac problems or they may develop some renal problems. So it's always very important that the patient have a good awareness of what their medical problems are, the new medical issues, what medications they're taking, and they need to be able to convey that to their movement disorder specialist so that adjustments can be made in the regimen as needed.
Someone also just wrote in wanting a little more specific guidance about a target to shoot for. Anything you want to add on that, Dr. Holler? Is there an ideal blood pressure that someone should really strive for when they have Parkinson's disease?
So in my patient population, I think my patients do best when their top number is between 120 to 140. That is often a very, very hard target to get to. And so between 100 on the top and 160 is oftentimes a more reasonable goal in patients who have autonomic problems and orthostatic hypotension. So that when they're standing, that's the key. When they're standing, the blood pressure is not going below 100, and ideally staying around the 120 mark when they're standing. That's often when the patients have the best perfusion to their brain and have the best recovery of any issues that they had with their thinking, their balance, and their walking. So we oftentimes, when we're starting to manage somebody with autonomic dysfunction, sometimes there are more wild fluctuations in terms of the numbers. But if we can try and get as close as we can to those goals, 120 to 140 in a tight control, 100 to 160 in a little less tight control, then we often have the best outcome.
And Jody, I'd be curious to hear your perspective on that. If you strive for a particular number, as Dr. Holler was just suggesting, and if you've noticed when you are at a good number, whether that improves the problems that you've experienced, particularly perhaps that foggy thinking that you were describing earlier in today's webinar. Jody, are you still with us? looks like maybe we've lost Jody. Any other thoughts on that question? Oh, Jody, go ahead.
I'm sorry.
Jody, I was just asking you. Yeah, go. I was just asking you, Jody, whether or not you experienced. Dr. Holler was mentioning that if you can keep your number in kind of the 120 range, and for that top blood pressure number, that's ideal, and that's when people seem to feel the best, think the most clearly, feel the strongest. And I was just curious if that had been your experience, that if you are able to keep it in a kind of targeted range, that improves how you do, particularly that foggy thinking problem that you described earlier in today's webinar.
Yeah, sometimes I have difficulty keeping it in that target range. It just it depends on day to day and how much hydration I've had. But I do when my blood pressure is in the higher ranges. For me, 120 is high. Actually, that's when I do feel the clearest and I feel the most energetic, and I have much less frequent falling, and but some days it is hard to maintain that.
Understood, but it does reinforce, I think, this point that this is a problem that can be treated by all the ways in which we've talked about today, and that we do that, we're able to perform in the way that we most want. I want to make sure we get to one other issue today that's an interesting tie-in to all of this, and actually provides perhaps some real hopefulness about something for helping to address the progression of Parkinson's disease. And that's that there's some interesting research going on right now that tests a drug for high blood pressure, a drug called isradipine, because we've noticed through epidemiological studies that people who are taking isradipine for high blood pressure either are less likely to ever get Parkinson's disease, or if they have Parkinson's disease, then it seems to progress more slowly. So this is a research that's been led in your town, Dr. Holler, in Boston by Dr. Michael Schwarzschild, and it's a really interesting story. Can you tell us just a little bit more about this, about why it might be that a drug for high blood pressure might turn out to actually be helpful for slowing the progression of Parkinson's disease?
Yeah, and I think this has captivated a lot of attention in terms of what might help in terms of slowing the process of progression of Parkinson's disease. And I think it highlights, too, that blood pressure is a piece of the puzzle, potentially, and also the mechanism of action of isradipine may help in terms of stabilizing some of the fluctuations that people are having with Parkinson's disease in terms of blood pressure, perhaps, or also has an effect, perhaps, on some of the blood vessel effects of patients with Parkinson's disease. So I think that what's also interesting is that the patients who were taking this medicine, they didn't really have a big drop in their blood pressure when they were taking the medication. And I think that that was a helpful feature in terms of the patients doing well with the medication as well. And I think it highlights, too, that any medication that is initiated for a patient with Parkinson's disease at any stage in their disease process, it is not necessarily going to be a good or a bad thing for them, and it's very individualized. So there are patients with Parkinson's disease who can do very well on isradipine and potentially use it to help slow the progression of their Parkinson's disease. So everybody is an individual in their disease, and we all just want to be carefully monitoring these aspects of motor and non-motor Parkinson's disease to optimize people's functioning.
And again, we're noting this because it is fascinating research, but we do want to underline the fact that it is still in the early phases of research. So we're not by any means suggesting that people run out and start taking isradipine. That's what we need to find out through the research that's going on now nationwide. But it's an interesting, as Dr. Holler suggests, piece perhaps of the puzzle of a potential way that we may be able to slow Parkinson's disease progression. We're coming to the end of our hour, and I just want to encourage people, as always, to participate in all forms of research. It's what will help us finally solve the puzzle of Parkinson's disease. Let me just get a last word from each of you, please, about the importance of this particular problem in Parkinson's, low blood pressure, and what it is that you'd like people to sort of leave today's webinar thinking about. Dr. Santini, just a first quick thought from you, please.
Yeah, I think it's very important that people identify that this can be an issue, and often just identification can often lead to the appropriate treatment. And so I also want patients to realize that there's a lot that they can do to take ownership of their disease and this condition in particular. And so we work with the patients, and it's really so amazing to have their help and their data collection in order for us to make the right decisions together for patients.
And Jody, you've provided such a great example of that, of someone who tracks this and provides that information to yourself, most importantly, and then to your physician as well. Anything that you'd like to add as a last thought on this topic for people who are currently struggling with this particular symptom?
Well, I would just say the data collection and keeping as much data as you can and share it with your doctor. You've got to be your own advocate. That gives you power, and that gives you control over your disease.
Jody, thank you. And Dr. Holler.
Yes, and so I would say that although Parkinson's disease can be a complicated disease process, we are learning more and more every day about issues pertaining to Parkinson's and to blood pressure that if we identify and manage can make a huge impact on people's quality of life and help maintain their stability over the years.
Thank you. Thanks to all three of you for providing such helpful information today, Drs. Holler and Santini and Jody Wright in Woodstock, Georgia. We really appreciate your participation in our webinar today. We'll be sending a link to the webinar on demand so that you can listen again or share with others. There'll also be a survey link in that email, which you can help us by telling us, giving us your thoughts and your evaluation of today's webinar. It really helps us fine-tune and improve our presentations. And then last, we just want you to ask you to please mark your calendar for our next Third Thursday webinar, which will be on Thursday, November the 17th, where we'll return to the topic of alpha-synuclein. That's that sticky protein that clumps up in Parkinson's disease and we think is responsible for the cell loss that triggers that cell loss in Parkinson's, and lots of exciting research developments in terms of ways that we may be able to break up that sticky protein, alpha-synuclein, and so that will be our focus on our next Third Thursday webinar on November the 17th. So we hope you'll join us for that particular session. Thanks again, everyone, for your participation today. I'm Dave Iverson.